go over a couple of these things first, and then we'll... All right. And this is where in the video it fades into me. We're going to go ahead and get started. Hannah. Huh? Now you're called out on video. So, why are we not able to see this? I don't understand. Well, I was going to pull up the agenda, but you guys all have it in front of you, so I think we should be okay. I'm not for sure why it doesn't show up. Let's try that one more time. There we go. So, thank you everybody for coming. As always, all of our meetings are recorded and placed onto our YouTube channel, so feel free to share it after the fact. A couple things of note. One of the handouts that are over there looks colorful, lots of yellow on it. Yellow is a good thing, actually, in this case, because this is our state alcohol and other drug policy updates. So you kind of get an idea of what's already moved through both houses. Just to give you a note, is that many of these that they say note opiate task force special sessions came out of the opiate task force special package of bills to address the rising heroin and prescription opiate epidemic. So you can see there that many of those have gone through. They are part of the HOPE legislation, which stands for Heroin and Opiate Prevention Education. Those are bills that have gone through now over the last 3 years. There's only one bill that didn't go through unanimously. Like, these are bills that have great level of support from top down. So just so then you kind of know what's out there. A couple of things, you know, when you look at the color-coded, there's 2 bills, including one that's specific to fentanyl and other synthetic opioids, as well as the tracking the sale of Sudafedrin products. Similar to the, if you go and buy Sudafed right now, they put your name down, they maybe take your license number, and that's not uniform throughout the whole state. Some people still use book copies, like a binder, and write it down. What this bill would do is to require it to be electronic, so that people can be able to monitor better if folks are buying in large quantities to make methamphetamine. So it's a good bill. I'd say it's definitely something that's supported, but you can see there's a number of bills that have been proposed for many different things. So if you have any questions, as always, let me know. They're kind of at hiatus right now, so not much has changed for the last couple weeks. Additionally, when we look at our stats or short-term action teams, for those of you that haven't been to one of these meetings before, the way that the AOD Partnership does their work is through action teams that have very specific focuses. So, for example, we have one on sober living. The goal of that group was first to come together and see what we need to have in our community for sober living facilities to open, what we currently have in our community and how we can help support them, and just kind of how we're going to move forward. So that group had very specific tasks, so you could kind of check them off and then move on. So people kind of come and go in those groups. One exciting thing that's part of that was recovery coaching, which put simply is between an AANA sponsor and a licensed counselor, someone with a higher level of training to be able to help individuals that are new to recovery or even in recovery for a while, create a recovery plan, connect them to the local social supports, and so on. We're going to have our first recovery coaching training at the end of August. We're really excited. 100% funded by Aspirus Health Foundation and Aspirus's Hospitals Community Benefits. We actually had a 25-person cap on that. We did reach our 25-person cap, and it's awesome. We have 25, actually I think 24 of the 25 are Marathon County residents who live or work here So we're pretty excited that we'll be able to offer that. That's the first of the many trainings that I can see coming. Also, one of the things you'll see in the partner updates is on August, 8th month is August 14th, a group of us are going to be going down to Step Industries, which is a transitional work site in Neenah. If anybody's interested in going on that tour with us, please reach out and let me know. For those of you that don't know me, I did undergo a name change recently, so now I'm Melissa Moore, formerly Melissa Dotter. I'm still getting used to it. I still write it wrong and everything, but just reach out to me. My phone number is still the same. You can reach me through the website if you're interested in going on that tour. But we're really excited. We've got a lot of great buy-in from our community partners, from the business community, from the treatment community, from the jail, and so on, to bring Step Industries here. So we're one step closer, I think, to making that happen. Also, when we look at board recruitment, 2018, we're going to be, I know it's hard to believe we're talking about board recruitment already, but we are 2 meetings away. December meetings when we actually vote in our new board class. We're going to be recruiting for our board. Applications will be coming out soon. So if anybody is interested in serving on the AOD Partnership Board, it is a local nonprofit, so you would be serving on a nonprofit board of directors. Currently, we meet monthly on the 3rd Monday, but that typically changes depending on who's on the board and who can make it to what times. We meet from 8:30 to 10, or we're scheduled from 8:30 to 10. If we're done early, we're done early. We always schedule an hour and a half just so then we don't end up going over really rushing at the end. For people that are interested in knowing more about that, we do have a couple positions available, including vice chair, which is a 3-year term, and then a number of at-large terms. I believe we have 5 at-large members that are available. So, the Faces of Recovery Luncheon and the Wisconsinite project on your agenda actually kind of go hand in hand. The AOD Partnership has 2 special events every year. We have our Spotlight event in the spring, where we focus on individuals or organizations doing great things in the community that help us achieve our mission. And then in the fall, we have our Faces of Recovery Luncheon. This fall will be our 5th event, and we usually use a mix of individual stories. We've used video. We've used, last year we focused on how we use art and art therapy to support recovery. And this year we're actually be partnering with Wisconsinite, which is Wisconsin's version of C-SPAN, essentially. And they're the folks that videotape all the legislative sessions, so if you ever really tune into that, there you have it. They are a nonprofit at the state level as well, but they actually developed a documentary called Straightforward, The Truth on Addiction. I'm going to show you guys a clip. It's about a 3-minute clip on this documentary, but at our Faces of Recovery Luncheon, we're going to be showing it in its entirety. The video itself is about a 50-minute runtime. I do not get geeked out over videos, but this video is phenomenal. From what I've seen of it so far, a couple of us have seen a little bit more than what you guys are going to be able to see today. But we're pretty excited because we're going to actually have the people that were part of the video making the video and is featured in the video at that event. So we're going to show the video in its entirety for about 50 minutes. Well, first we're going to get our food, show the video, and then if you're planning, we're scheduling 2 hours for our event, but that last half an hour to 45 minutes is going to be opportunity to talk with the panel. So I hope that you can make it. We're also going to be doing an evening session that night. So if you can't make it on the daytime on the 12th, we're going to do an evening session that night, also showing the video its entirety, as well as including the panel and folks that are part of that. So we're really excited about that partnership. WASA is actually one of, I believe, 4 locations in the state that have been selected to premiere this video during the month of September, which is National Recovery Month. So this is in partnership with Wisconsin as well as the Department of Justice. So we're pretty excited to be brought in and be part of that. And we also invited a number of our schools to also show that video and take advantage of having that panel here the day following that event. So before I get to the video, I'm just going to wrap up the partner updates and invite partner updates from the group. The Joseph Project is actually, it's a program, and I think I forgot to put it on here. Darn it, I knew I forgot something. The Joseph Project is actually a faith-based program that came out of Milwaukee, and Ron, correct me when I'm wrong here, because you might know more about it than I do. But the Medical College of Wisconsin is working with Greater Wausau Christian Services to bring the Joseph Project here. The Joseph Project helps individuals that are incarcerated or getting out of treatment to connect them to employment, to help reduce the roadblocks to them to keep that employment, such as transportation. So it's kind of a neat program. It's community-based, faith-based program. There's going to actually be an informational session tonight for anybody that's you feel might be interested in being a part of it. And I do apologize, I don't have it here with me, but I will look it up on my computer and I will let you guys know at the end what time and the location. But they're doing an information session tonight, and then it will for individuals that are interested, and then there's a 5-day, I believe it's 2 hours a day sessions for this project, which lead up to meeting with actually Colby & Colby as their business sponsor. So Colby & Colby will be meeting with people that go through this project. And I believe it includes things like soft skills, applications, how to go to an interview, resumes and so on is all part of that project. So if you know of anybody that's interested that maybe is in recovery, maybe is struggling to be part of that program, I'll get more information up then before we all leave today. Other things, don't forget your evaluations. Hopefully you all grabbed one. We're actually looking for local stories to help populate the next version of a memorial quilt. And it's actually a pretty neat project. We've actually had the memorial quilt a number of times here now in Wausau. We've had them here twice. And then I actually have the squares here today. And I have the information on how to create a square, but essentially the colors mean different things. There's individuals that are incarcerated, there's individuals that are in recovery, there's individuals that are in active use or active addiction, and then there's individuals that have passed away due to their addiction that are part of this, which that's what the different colors mean on the quilt. So I actually have the squares here, like I said. If you are interested in doing it, if you want to be part of the quilt but maybe don't have time to make one yourself, there's actually instructions on how you can send a photo to Bev, who really helps spearhead this project. So again, more information about this is in our weekly updates. If you're new today, we sign you up for our weekly updates. It includes meeting announcements, drug trends, training opportunities, a variety of things. It's our way to keep you in the know. That information will be included again in the update this week. The the DEC conference, the Drug Endangered Children Conference, there's still I believe there's still scholarships available for rooms. Very low cost for national training. So if anybody has interest in attending, I hear rooms are kind of scarce around the Green Bay area right now, but it is a great opportunity here. And for anybody that works or lives in Western Marathon County, they haven't set the meeting location yet, but the next meeting for that group is September 20th. One of the things that group is working on is the Youth Risk Behavior Survey data collection, as well as we're going to be launching the videos that go along with our local data coming soon. So hopefully I'll have a snippet at our next meeting for those. And a training come up. How many people here have seen Paper Tigers? So Resilience is actually the next movie in the next movie following Paper Tigers, really looking at stress and the science, they call it the biology of stress and science of hope. But for anybody that's interested in going to this, I don't believe there's any charge for this training. Lunch is going to be available, I believe, on your own, but there's on-site, they're going to have food trucks there at DC Everest Middle School. So this is an opportunity that'll go up through the update this week. It's Monday the 14th. And for anybody that's interested in learning about kind of accidental ingestion, if you're a first responder, law enforcement, EMS, they're actually going to be doing a training specific for that population coming up here. Again, it seems like everything's happening around the same time. That one's on the 15th. Again, this one just came to me as well. Don't know very much about this concert, but Ron does.
Yeah, it's Friday, the 400 block, 5 to 10. We got 3 bands. It's Naomi is one of the sponsors. There are several organizations that are involved. It's kind of designed as an alternative to the Ted Nugent conference that's going to happen on the same night. And we're trying to focus on healthy family activities. We'll have activities for the kids. It's all free. And love to have you come out and spend some time and celebrate diversity and unity in our community.
All right, thank you. So great free opportunity. With that, is there any partner updates before I roll the clip? I just really wanted to say that.
Addiction's known as a family disease because it doesn't just impact the person that's using. It impacts people's family, their friends, their coworkers, their teachers, everybody. If you've known anybody that's ever struggled with active addiction, it's probably impacted you.
It hit us like a ton of bricks when she went into the hospital the first time with heroin overdose because we had no idea. So that was a huge shock. We did not see it coming.
No, not at all.
I didn't know what to do or how to feel. I was literally, I couldn't hardly think of what to do.
I was furious, hurt, embarrassed, walk around with knots in your stomach 24 hours a day, waiting for the next call. What's it gonna be? What is it? You know, the begging, the
Threatening.
It was just,
The deal making, just the constant, the phone would ring and your heart would just stop because you just were expecting it to be that phone call that said she's gone.
Pretty amazing, really, from where she was to what she's doing now. I mean, assumed a funeral was coming before anything, really.
But it all came crashing down just as it always does. My parents put me on the streets. Enough is enough.
she's done controlling our lives. It's not gonna happen anymore. And I made the decision, and it was the hardest thing I ever did. I said, she's not coming back in the house till she gets stuff together. By making that decision, there's times she showed up, rain and cold, whatever, and I turned her away. I said, nope, you're not coming in here. I mean, I didn't let her know, but I went back to the room and cried because that was my daughter that I just said no. But I had to, for us, for the family.
So I've watched that now probably 15 times. I cry every time. So that's why, like I said, I think this video is it's something that's going to be available for a long time. It's going to be free. There's going to be curriculum attached to it. Schools can use it. Anybody can use it. And we're really excited to be able to bring it to you, to bring it to our community. We're actually the first showing in the entire state on that day. So it's pretty awesome. So hopefully you guys can make it. Registration is going to come out for that event. That's the question of the day on the sign-in sheet. So hopefully everybody got the sign-in sheet. If not, I've got another copy back there we can start passing around too. With that, are there no other partner updates? We'll go right ahead into Sarah's presentation. And just a reminder again, if you want CEUs for today, fill out these forms, leave them at your spot with your evaluation. And one other additional material that was set out is I actually put together a timeline. One of the things we've been trying to do through the AOD Partnership is build communities that are supportive of recovery. And that's looking at things like employment, things like recovery coaching, sober living, and so on. So I actually put together a timeline of all that's happened in really pretty much a year. A ton of great things. So if you're interested in that, there's a timeline that looks like this over there. There probably is enough for everybody. If not, I can always send it to you. So I have nothing else. Sarah, if you'd like to come up.
So good morning, everybody. My name's Sarah Walder. I'm a nurse practitioner from the Aspirus NICU in Wausau here. And I'm going to talk to you a little bit on the impact of addictions on the fetus and the newborn. So I'm a medical person. I tried not to make this super medical. I know there's some public health people here. But where is everybody else? I know Chelsea and where's everybody else from? Who am I talking to? Where are you guys from?
Children's Service Society.
Okay.
Health Department.
Okay, public health, okay.
Women's Community.
Women's community, okay.
State Department of Health Services.
Okay. Counselor, okay. I just like to know who I'm talking to. I know you guys.
Big Brothers Big Sisters.
Okay,
Head Start.
okay. Up here?
Health educators at the health department.
Okay, very good.
Social services.
And social services, okay. All right, very good. So I tried, like I said, I tried not to make it too terribly medical. If I'm covering or not covering stuff that you have questions about, I'd rather have this be a little bit more of a conversation than me talking to you. So please feel free to add anything in. There's a lot of people here with a lot of experience dealing with this issue. I deal with it so from a prenatal perspective as well as postnatal, but once they leave our hospital, I don't have a lot of contact. So I'm very focused. My focus is pretty narrow, but hopefully I can shed some light on a few things for you. So what I decided to do, because when I was talking to Melissa about this, most of the research that you see out there and the experience has been alcohol and opiates. That's the highest incidence. Marijuana's creeping up, but that is typically the highest incidence of babies that we see, probably a lot of children that you see. You know, the thing with medicine and with treatments, and especially with babies, is it's difficult to do, right? Because you can't tell this pregnant woman, I'm going to give you LSD throughout your pregnancy and let's see what happens to your baby. So most of the research that's been done has been done retrospectively, and it's been just observations. It's not a lot of good medical literature. So anyways, I'm focusing on alcohol and opiates. Talk a little bit about marijuana just because there is an increased incidence, and as you guys are all well aware, the marijuana of my age is very different than I think what it is now. So I touched base a little bit on marijuana, and then stimulants, sedatives, hallucinogens, not a lot of information, but I do have a few things to share with you. So in the prenatal clinic, I talk to women in the prenatal clinic if I get the opportunity. It depends on the situation, but I try and talk to them in the prenatal clinic if I can. I do go to the WASA Treatment Services. Is that what it's called now? Nobody knows? We used to call it the methadone clinic, but it's not called that. Comprehensive Treatment Center, that's what it's called? Yeah. So I try and hit their pregnancy group. I try and get there a couple times a year just to talk to them about what to expect. But so everything kind of starts in the prenatal clinic. And I know a lot of the money, I was here at the last meeting when Jen was talking, and they're doing a pilot project or something in the area on psychologists coming into the school system or something like that she was talking about. It's a really kind of a neat program. But this starts way back, a lot further before they hit the school system. So in the prenatal clinic, what we try and do is we try and screen women for drugs of addiction. What ACOG recommends is that we screen all women with a tool, with a validated screening tool. So typically, like, that's the CRAFT or the NIDA screening tool. I forget what that one's called. 4Ps, those kind of things. And then from there, we work our way up. So that's kind of what we do in the prenatal clinic. Try and screen them and then hopefully get them help. The thing about pregnancy, couple things about pregnancy is, we all know how powerful that addiction can be for a lot of these women, but pregnancy is really great to get them before that, but pregnancy is a really good opportunity for these women because, number one, they're a shoo-in into any clinic, right, into any type of addiction treatment program. So they don't have to sit on that waiting list. And number two, most of those women are in that mindset, hopefully, to try and get help for their baby's sake, right? Because now it's not just about them, it's about this baby as well. So I see pregnancy as a really huge opportunity. So if we can identify those women, we can hopefully get them help. The difficulty of that is that a lot of women don't want to tell us, right? They're afraid of social services coming in. They're afraid of getting that baby taken away. So hopefully we can present some of these things, and obviously you guys know, being in the community and talking to some of these women, that some providers are really good at that and others aren't so good at that. So when I go into the clinic, I do try and direct them to ones that are a little bit better at dealing with that. But so when they go into the prenatal clinic, we're looking for those risk factors. We're screening all the women. We're working our way towards screening all the women verbally. We don't urine drug screen all women. Those are select people. So we look for risks, right? And these are kind of there's a couple slides of some of the risk factors that might tip us to that maybe there's an addiction problem. So late, minimal, or no prenatal care. A lot of those women are afraid to get care. They're afraid of being turned in. They're afraid of social services. So they don't seek out prenatal care. Multiple missed visits, so they're scheduling their appointments, but they just don't show up. And sometimes, there's when you have a woman that's dealing with addiction, there's a lot of factors that can play into that, why they might have missed appointments. Abnormal behaviors, we've seen that in the prenatal clinic. We've seen that after women are laboring, right? So they were laboring, and I don't know what their drug of choice may be, but now it's been, if their labor was 12 or 18 hours or whatever it ends up being, they haven't had their fix for that long. So they do start to see some of those abnormal behaviors, signs of withdrawal, things like that. Sexually transmitted infections, if they have frequently occurring sexually transmitted infections, that just points us towards more risky behavior patterns that indicate potential for substance abuse. If you look at their past OB history, that can sometimes tip you off. So frequent miscarriages. Now, none of these things in and of themselves, because there's a lot of women who they haven't been able to carry pregnancies, or, they've had issues, they've had premature births. But if you take them as a whole picture, sometimes it will tip you off that maybe this woman needs more help. So frequent miscarriages, growth restriction, that's growth restriction in a fetus. So sometimes those babies just don't grow well in that hostile placental environment, in utero environment. Premature birth, placental abruption, so that's when the placenta starts to pull away of the uterine wall before the baby's born. Babies don't sometimes survive that. That's classic of cocaine use, actually. Stillbirth. And then precipitous delivery, so that's a delivery that happens really quickly, so they come in and they deliver, or if they have a history of just coming in and delivering very quickly, because labor typically, not for all women, but typically takes a long time. So another indication that's classic of cocaine abuse. And then some social factors, if you're talking to the moms and all of a sudden you get talking about their other kids and you find out they're not living with their mom or they're involved with CPS. History of medical problems associated with drug abuse. So, pregnant or women that get pregnant, right, are typically pretty healthy. I mean, they're young. So if they have a history of cellulitis, skin abscesses, endocarditis, which is an infection in the wall of the muscle wall of the cardiac muscle wall, an infection in the bone, osteomyelitis, any kinds of suspicious trauma in their past history, hepatitis, infection in the liver. Phlebitis is an infection in the veins, so that would indicate IV abuse, tuberculosis, so some of those medical problems that can be associated with substance abuse. And then physical signs of drug use, so track marks, things like that. Any physical signs of withdrawal, which we've seen in the past, nausea, vomiting, difficult to detect in pregnancy. We're all nauseous and vomiting at that point, but if it persists, poor teeth, poor weight gain during the pregnancy, any diagnosis of other mental health disorders, because as we know, mental health disorders are linked to an increased incidence of substance abuse. Family history of substance abuse or a partner who is a substance abuser, because sometimes, and especially until you develop that relationship with a woman, they don't really want to talk about their substance abuse necessarily, but they might want to talk about their partners or their fathers or other people in their families. So sometimes that can help get an in and talking about it that way. So any questions about that? About the prenatal stuff? That's kind of all I covered with prenatal. But so that's what we, try and do to try and identify, because the biggest thing is you have to identify these women or you can't help them, right? So now I'm just going to go on to talk about the different types of drugs and their effect on the fetus and the baby. So we'll start with alcohol. And alcohol is still one of the worst teratogens out there. And it's still a huge problem. I don't know if it's because it's legal. I don't know. We don't see a lot of fetal alcohol babies, or if we do, we're completely missing them, because women aren't coming to us and saying that they have an alcohol problem. I don't know if they don't realize it. I don't know. But I'm sure that there's more out there than what we know. I can remember, so I've been at Aspirus 20 years. Oh, that's hard to say. I've been in the NICU since its conception in 2006, so it's been 11 years now. And I can remember one case of fetal alcohol syndrome that was a definite diagnosis, but I'm sure we've missed plenty. So just a little bit about the diagnoses. Fetal alcohol spectrum disorder, that's the term that encompasses a range of different effects that occur from the alcohol. And it's specifically from prenatal alcohol exposure. So this is just kind of a graphic just to kind of help you understand a little bit, and it gets a little bit medical. I don't get into all of these different aspects of it, but fetal alcohol spectrum disorder is the broad term, and then you've got the offshoots of that. So you've got fetal alcohol syndrome, the ARBD is alcohol-related birth defects, partial fetal alcohol syndrome. The next one over is neurobehavioral disorders associated with prenatal alcohol exposure. And then the ARND is alcohol-related neurodevelopmental disorders. And it's just all, it's all under that umbrella, but there's just some minute differences in the diagnoses when you go to look at them. But clinically, a lot of them, it's very similar. So those of you who have seen these babies, they will have characteristic facial features, and I didn't list them all here, but they tend to have very small, the inner and the outer canthus is very short, so their eyes look really small. And they also look wide-spaced because of the shortness of the wideness of the eyes is kind of just a little thinner, slimmer here, but it's wide-spaced between the two eyes. They have a thin upper lip, and then the smooth philtrum. So that little dent that's above your upper lip there, that dents in, theirs is very smooth. So there's some pretty classic facial features. There's other things, but those are what you kind of tend to see. A lot of those babies are growth restricted. So their height or weight is less than the 10th percentile at any point in time. And growth restriction, there's two types, symmetric and asymmetric. So an asymmetrically growth restricted baby, the brain was spared. So their head looks big compared to their body. In fetal alcohol syndrome, that tends to be symmetric. So they have a small head circumference because their brain was involved. It took a hit. So their head circumference is small, their growth is small. They have structural abnormalities in the brain. If you look at images of their brains, they're actual structural abnormalities. And abnormal neurologic signs, and then recurrent seizures many times. So the biggest thing is the neurodevelopmental impairment that comes along with the exposure to the alcohol. These kids have a lot of problems, and these are the kids that you see in the school systems and later on in the community that have so many issues. So the overall intelligence, the overall IQ of these kids tends to not be below the threshold for considering them disabled. So it's not less than 70, but they tend to have lower IQs. It can, however, range between 20 and 120. So you can have overwhelming disabilities to actually very smart. Do you guys know what the average IQ is in the United States? What's your guess? Throw out a number. I think I heard 90. Close. It's 98. The average intelligence in the United States is 98. We're ranked 9th in the world, so we are not one of the smartest countries. So anyways, they do have some of these cognitive impairments. They tend to have difficulties in math. That's kind of the most common, but they can have difficulties in language, reading, spelling. They tend to have other cognitive problems like impaired memory, slow processing. Of the speed of the processing of the brain is kind of slower. They can have issues with executive functioning, so planning, relating cause and effect, things like that. They can't consider the consequences of their actions, or they can't generalize knowledge from one situation and apply it to the next, things like that. Their social skills can be affected, poor understanding of those social cues, lack of remorse from after misbehaving. lack of appropriate initiative. There's those reciprocal friendships don't tend to be there, social withdrawal, things like that. And you know, the problem with children that are exposed to any substance, it's difficult to determine whether or not, I thought I saw it click off, whether or not it was from the exposure or if it's from the environment that they're in, because typically those environments tend to not be as conducive to proper growth. So it's difficult to tease those out. So when we talk about some of the long-term outcomes of these drugs, and including alcohol, it's difficult to determine what's caused by the actual substance as opposed to the environment. So these are just pictures. You've probably seen these on children. So you can see, especially I think in that top left picture, that little girl there with the really wide spaced eyes. You can see all of them have that very thin upper lip and then the smooth philtrum, right? So it's just different races and kind of how they appear. But that's very smooth up here and kind of long because of that thin upper lip. So those are the classic facial features of your fetal alcohol spectrum disorder kids. So as I mentioned previously, alcohol is a teratogen. It's got irreversible central nervous system effects. So once those effects are there, there's no way to reverse them. There's nothing we can do to fix that. The damage has been done. Like I mentioned previously, if you image their brains, it does demonstrate abnormal brain structure and function following any prenatal alcohol exposure, and the amount has never been determined. So that's why we just say no alcohol during pregnancy. Some of the abnormalities that they see upon imaging in the brain are listed there. So the volume of the brain is smaller, which is why they tend to have small heads. But they have specific reductions in certain areas of the brain. And these areas are the areas that influence the impulse control, the judgment, transfer of information between the two hemispheres. That's a corpus callosum, that second bullet point there. Memory, learning, motor coordination, ability to work towards goals, and the perception of time. So those areas of the brain are specific to some of the abnormalities that you see in these kids. Again, the safe threshold or pattern of alcohol consumption has never been identified, so the best option is no alcohol use during pregnancy. The fetus is particularly vulnerable to maternal alcohol consumption because they can't eliminate it, and then the exposure is prolonged. So, well, I don't know if anyone wants to hear this, but so when amniotic fluid is made, much of it is actually the baby's urine, okay? So what happens in babies, in moms that drink alcohol, that alcohol crosses through the placenta, it gets into the baby, they eliminate it through the kidneys, so they pee it out, and they swallow it, and it recycles through their system. So their levels are can be much higher than what, and much more prolonged than what the mother's actually exposed to. So just kind of one of the reasons why it can be so significant, the impact is so significant. Can cause bad effects at all stages of gestation. So first trimester, you're gonna see more of the brain anomalies, the facial stuff, major structural anomalies. One of the major structural issues that those babies have is cleft palates. So you can incidental cleft palate that a lot of times can be from fetal alcohol syndrome. In the second trimester, they tend to have more spontaneous abortions or miscarriages. And then the third trimester is really affecting the weight, length, and the brain growth. Those babies in that third trimester have a rapid period where that brain because the growth accelerates tremendously. And so it affects that brain growth. The neurobehavioral effects that you see, which we kind of talked about previously, can occur with a range of exposures throughout gestation. So it's not like you can say, well, I'm going to wait till, or it's not like a woman can say, I'm going to wait till the third trimester because all of that development of the organs is done, and now I can drink in the third trimester, because the neurobehavioral effects can still be there. And you can have those effects even if you don't have some of the structural brain abnormalities or the facial features. And then a significant proportion of women, right, as we all know, don't even know they're pregnant until, sometimes it's not even until the second trimester. Some don't know, I don't know how, throughout the whole pregnancy. We've seen that happen too. So they may not know, and the damage has already been done because they don't know they're pregnant. So their prognosis then as adults, kind of the long-term outcomes that you see with the kids that are affected by repeated alcohol exposure in the womb, they tend to have inappropriate sexual behaviors on repeated occasions. The numbers here are from one study that I found on a long-term study that looked at the outcomes into adulthood, which is unusual. So it's only one study, but it was a significant amount of people. They have disrupted school experiences, so truancy and those kind of things. 61% trouble with the law, confinement, so jail, and they also have issues with alcohol or other drug problems as well. So long-term outcomes aren't good either. There is no treatment. Like I said, once the damage is done, it's been done, so the only thing you can do is try and prevent it. Fetal alcohol spectrum disorder is still the leading preventable cause of birth defects and developmental disorders in the United States. So, individual treatment is required for these women that are diagnosed. They need many specialties to improve their outcomes. The women and then subsequently the children that are born to these women are very draining on the system, on society. They're stigmatized as kids, which can lead to other issues as well. So, I don't know, that just makes me think, so you guys probably know more about this than I do. What I do know, and I know Melissa knows more about this because we talked about it at one point in time, but so there used to be a law in the books, so I want people to comment, on that if a woman was habitually, and there's wording, exposing a fetus to drugs of addiction, that she could be put into basically a treatment program, not involuntarily. Yeah, so does that, yeah, I know Melissa knows about it.
Yeah, I was just looking it up.
You were just looking it up?
There's been some changes.
Correct.
Challenges. It's the
Correct.
cocaine law.
Yes, yes.
But I will pull it up.
Okay, that'd be great. Because I know that there's recently been some changes. One court, I think Taylor in Taylor County.
For social services, you guys.
Well, I was going to say,
Yeah.
we had it on hold for a period of time because of the changes, but
Okay.
now it is that we can do what we call U-chips to take a pregnant mom into custody.
Okay.
To get a protective order for that.
Okay. So we can, there's still a way that we can,
Right.
okay, do
And as
that.
mandated reporters, we still report.
We still report, correct.
Whatever the legal issues are.
Yes, so that, I mean, that brings up another good point, the mandated reporting thing, because I do know, because we have obstetricians in our facility, and so talking to them, they're really uncertain of sometimes what to do, because they may know this, but they don't always report. And it's a delicate balance between continuing prenatal care and taking care of that woman and patient-client confidentiality or patient-doctor confidentiality, and so I know we've had these discussions a lot because.
Well, I was going to say, I think I always encourage a mandated reporter to report, and our goal is really to help them get services
Yeah.
and support.
Yeah.
So that the baby is
Taken care of, yeah. So it's always a little bit of a cause for controversy about that. We've had lots of conversations about that. And I think most of our obstetricians will try and get them help. They'll get our social workers to talk to them and get them into a treatment program, or try to get them into a treatment program and go from there. And but it's good to know that we, because if a woman is not in the mindset that they want to get help, to seek help, and they continue to abuse, and that we can report those women and hopefully get them into treatment. Okay, any questions about alcohol at all, or thoughts, comments? Yeah.
So if a woman was drinking and say like the second trimester she stops, is there any withdrawal that the baby goes through in utero, or do we not know that?
We don't know that, and likely because but you have to consider the stage of development that they're at. So all of their organs are going to be developed, but the neurological system is not well developed at that point yet. So nobody really knows what kind of, what they might be feeling in there. I don't think it's a far stretch they definitely have something. I mean, you have to, even at that stage of the game. Yeah. It's a good question. Anything else? Okay. Moving on to opiates. This one's near and dear to my heart because I take care of these babies all the time. So just some consequences of maternal opioid use. It's we've covered some of them in previous slides because it is consequences of addiction in general. So sexually transmitted infections, HIV, that's typically from IV drug use, and hepatitis, same thing, endocarditis, the infection in the heart, infection in the bone, sepsis is a blood infection, infection in the tissues, things like that. And then just the chaotic lifestyle that comes with addictions typically, so prostitution, violence, theft, diminished commitment to health care, so they don't show up to their appointments, they don't seek prenatal care, they can get infections in the amniotic fluid at any point in time, and that definitely affects the baby. Those babies tend to be born preterm, they tend to be born septic, so they end up with a blood infection and they're really, really sick. Preeclampsia, that's just high blood pressure during pregnancy. So the placenta, it doesn't function quite as well, hence some of the growth restriction and things like that you see. That can lead to premature birth, things like that, miscarriages. And then they're at high risk for postpartum hemorrhage as well. So bleeding after the baby comes, significant bleeding. Outcomes in the fetus and the newborn, again, the growth restrictions, so that's what that's a picture of. So same gestational age baby right there. One is healthy, full term. The other one's full term, but is severely growth restricted. So abruptions, we talked about that. That's when the placenta pulls away from the wall of the uterus, and some of those babies don't survive that because anytime part of that placenta is not in contact with the maternal circulation, the amount of nutrients and oxygen and everything that the baby needs is decreased, and they can bleed profusely. Death, premature birth. They can have abnormal fetal heart rate tracings during labor, which leads them to higher risk of C-sections. A small, that's occipital frontal head circumference. It's basically a small head. And have left space. And then, of course, you've got the adverse childhood experiences that can occur as a consequence as well if those behaviors continue. And then the neonatal abstinence syndrome, which is something that we talk about a lot. So it's a complex disorder. It's defined as a constellation of behavioral and physiologic signs and symptoms involving multiple symptoms. And for those of you that have seen a mom withdraw or a person withdraw, it's pretty much the same thing. Babies do the same kind of things, but they just don't have those seeking behaviors because they can't, right? But it's caused by the sudden discontinuation of exposure from the exposure as a fetus to the substances that were used or abused by the mom during pregnancy. So when you talk about neonatal abstinence syndrome, that's pretty much opiates. Other substances will cause withdrawal symptoms as well. It's just they're not as well defined as we are with opiates. It's pretty well defined. SSRIs have been linked to more of the same behavioral and physiologic patterns that opiates tend to be as well. So I included SSRIs, and those are prescribed, right? But, for a lot of, I don't know if you guys have heard any of these stories, I always, most of the time, once they're in the NICU and the babies are withdrawing and however we're managing them, and we'll talk about that in a little bit, you get a chance to talk to these moms, and you get a chance to ask, questions, and sometimes it's very eye-opening sometimes. And unfortunately, many of their stories start with, well, I was in a car accident and I broke my leg or whatever, and I was prescribed Vicodin. And it snowballed. And I don't know, you're probably seeing it now with the increase in heroin. It's because opiates are much harder to get now, right? At Aspirus, they're doing a project. But it's funny, because you always have unintended consequences of anything you do, right? So they start talking to all the providers, Aspirus starts talking to all the providers about prescribing opiates and how we have to be careful, and we gotta do this, and we gotta do that, and we had, experts come in, and then what people take home with that information. So then they take it home, and then what was happening is they've had somebody on opiates for 5 years, and all of a sudden they won't prescribe them anymore. What are they gonna do? So now they're seeking out other ways to get that same feeling, and because now it's an addiction. And so then they backtracked and they're like, okay, we have to be careful, but you can't just cut somebody off cold turkey. So it's kind of those unintended consequences, but we created a lot of this problem, right? So we have to help solve it. So you guys probably know this already. These are common drugs leading to neonatal abstinence syndrome. There's a whole boatload of them, but these are the ones that we see the most common. Maybe I'll get to that. Okay, so if you look at moms that are taking opiates, prolonged exposure to opiates, the fetus was, NAS will develop in about 55 to 94% of those babies. So not all of them, sometimes a lot of them, but only about 30% of those babies will require pharmacologic management. And I'll talk a little bit about how we try to manage those babies, because we try and manage them non-pharmacologically as much as possible. And then the clinical course and how they do varies depending on lots of things, what the mom was taking, long-acting, short-acting, opioids, her history, how long she was taking it, baby's metabolism, the mom's metabolism during pregnancy, the placental metabolism. There's just a lot of factors that roll into it. And then typically, as you probably are aware, there's a lot of other exposures. So most of them smoke. So you've got the nicotine exposure, and those babies are wild right when they come out. They don't make little nicotine patches for babies, so they just kind of have to deal with it. And then, other substances they may have mental health issues, they may be on some of those substances as well, and so there's a lot of factors. Just looking at timing of withdrawal, I don't know if anybody's interested. So some of the more short-acting opioids like morphine and heroin, withdrawal is usually 2 to 3 days. As far as when you, that's usually as long as it lasts, is a few days, just because it's short-acting. So it tends to leave their system relatively quickly. Long-acting like methadone and buprenorphine, that does tend to linger a bit longer, those withdrawal symptoms. Some of those babies can show some mild symptoms for months out. SSRIs and tobacco, you can see the timing as well. This is just an interesting slide I threw in here. You guys are probably familiar with how much this can potentially cost. And this is kind of old too. So it's almost 10 years old now. But you can see the difference. So if you look at the bottom, oops. Oh, sorry, I hit the wrong button. I was going for the pointer. Okay, if you see the bottom, so this is your this bottom section right here. That's your that's your average length of stay, average cost for a birth in the U.S. So in 2009, I mean, obviously prices have increased. We all know healthcare's gone through the roof, but so in 2009, if you look at the last column, you can see that, so that's about 1.1 million babies. The average length of stay was 3.3 days, and the hospital charges were close to $10,000. In the top section, right up there, you can see the average length of stay, average cost of a baby with NAS. So you can see how it's just very draining on our resources, on the system as a whole. So $53,400 in 2009. So what do we look for with babies? They have classic central nervous system disturbances, excessive high-pitched cry, and it is ear-splitting, and it is very difficult to deal with. So you can understand why we don't want to send these babies home with moms who already have very minimal coping mechanisms, right? And you send them home with a baby like this, they would not be able to manage it. And the fear of child abuse is pretty significant. Because some of our nurses that take care of these babies at a certain point in time probably want to throw them against a wall, but we don't. significant interruption in the sleep pattern. These babies don't tend to sleep a whole lot. And if you don't sleep, right, your brain cannot function appropriately. It can't develop normally. Hyperactive reflexes, different reflexes, they're tremorous, they shake. Increased tones. So you know how babies, like, if you pick them up, a newborn, if you pick them up by their arms, their head lags like this, those babies they're just stiff as a board. They don't have any of that head lag. It's hard to change their diaper because you can't get their legs to go down. They are just clenched up in that fetal position. Excoriation, and that's basically so that's, all over. They can get red, and they can, the last baby we had rubbed blisters on her heels so bad. It's just because they're so frantic and continually moving, and it's just friction on the bedding. Jerks, myoclonic jerks, they can sometimes look like seizures, but they are a little bit different, and then they ultimately can seize. And the highest incidence of seizures is actually between 1 and 2 weeks of life. So if these babies, a lot of them are going to go home before that time. So they have the potential for seizing at home. And then they have metabolic, vasomotor, respiratory issues. So they sweat a lot, they have a fever, frequent yawning and nasal stuffiness. Mottling, that's the picture I've got there. It's kind of that marbling look to the skin. It's just their autonomic nervous system. Nasal flaring, they breathe fast. They have excessive need to suck. These are not breastfed babies for you home health or public health people. And you guys are probably aware of this, but we're very pro breastfeeding, and I can talk about that too, but I better speed up. Okay, we're very pro breastfeeding, but these are the babies that you have to give a NUC to. These aren't the ones that you say, okay, wait until 2 weeks after breastfeeding is well established, and then you can introduce a NUC. These are kids that, in order to manage the symptoms, need a NUC. They don't eat always, so the last kid we had, this last kid that we had was severe and could not eat. We had to tube feed him. She couldn't eat. They vomit, lots of loose stools. Back up. Okay, so then all of this basically leads to poor growth, poor development, those kind of things. So you have to intervene with some of these babies with pharmacologic treatment. So for moms that are addicted, methadone and buprenorphine are the two treatment regimens that most people will use. Buprenorphine is a little more controversial. It's newer. Otherwise, methadone, some of the other ones they don't use with pregnant women. So when I go and talk to the women in the I'm just gonna call it methadone clinic. I know that's not its name, but because I can always forget otherwise. Because I think a lot of times the women that are actually getting treatment feel stigmatized, right? Because these are the ones we know about. These are the ones we're watching. These are the ones we're going to keep their babies for 5 to 7 days. That's what the AAP recommends, is we keep their babies for 5 to 7 days to watch for those withdrawal signs. Their babies have to go up to the NICU, their babies have to do this, their babies have to do that, and they have to stay. And my friend, who was strung out on heroin all the time, got to take her baby home at 24 hours. It's difficult for them. I think they feel like they're being punished for getting treatment, and so we talk a lot about that because it is what's best for the baby, and they're doing the best thing for their baby. So we have a lot of conversations about that, but those are basically the two treatments that moms get. Buprenorphine, this is just anecdotal. There's not a lot. There may be a couple studies now out there on buprenorphine, but we have seen less incidence of neonatal abstinence syndrome on those with those babies where their moms are on buprenorphine. So it seems a little bit better, but again, more anecdotal than anything else. So we'll see. I'm sure there'll be more studies. We'll see what happens with that, and maybe that will become the drug of choice. For babies, we try and manage them as much as we can non-pharmacologically, and I think I put slides in here coming up what we do with them. If we have to treat them pharmacologically, at Aspirus we use morphine. It's short-acting. It's a little easier to control. Some places will use methadone. It's just longer acting, and sometimes to get on top of it is hard with methadone because you can't give a rescue dose of methadone because it's so long acting. So with morphine we can treat, and then if they need a little bit more we can give them another little bolus of it, and it's oral. It's just given oral. So that's what we use for babies. I did not put, oh, sorry, I didn't put, so some of the non-pharmacological things that we do for the babies, it's nice in the NICU because every baby's got their own room, so we can manage the room how the babies need it. So a lot of times we'll make it very dark. We just basically try and make it very non-stimulating. So we keep it dark, the noise is at a minimum, keep them tightly swaddled. We do a lot of holding. We have cuddlers that come in and hold our babies, rock them, because all of those things kind of help with some of those symptoms. We swaddle them up tight. Emily, our nurse, is the best swaddler ever. Frequent feedings, we use lactose-free formula. It can sometimes manage some of those GI symptoms. They're not lactose intolerant. So if you guys see those babies, like we send them home on lactose-free, you can switch them over anytime. It's just to manage those symptoms. They're not lactose intolerant, especially you guys in public health when they come back, when you go to see them. But it will help manage some of those GI symptoms. So those are kind of some of the things that we do just to help those babies get through those withdrawal symptoms, hopefully without treatment. When we decide to treat, those babies can't eat, can't sleep, and they can't gain weight. So if they're not able to do those three things, then it's time to treat them. And there's a scoring tool that we use. It's a little more objective than that, but that's kind of the gist of it. So outcomes, again, it's hard to determine whether it's from the actual medication or if it's from environment. It's probably a little bit of a combination. But there has been some studies pointing towards behavioral problems, particularly aggression. They tend to have decreased attention spans, learning and memory deficiencies, anxiety disorders, and increases in depression, which there's not a lot of people from the school system, I guess, but you guys, I'm sure, see it in the school system a lot and out in the community. I just wanted to put these up here. I helped create these. This says the Wisconsin Association for Perinatal Care. If you guys aren't aware of it, I mean, it's for moms and baby people, right? But it's a great organization. They've got a lot of resources out there, and they have some community resources out there as well. But so this is what we hand out to families. It's a pretty little, it's a trifold thing. I just couldn't, you can't see it like that, but it's a guide for parents, and it lists all of the baby's behaviors that they might see and some of the things that they can do for them. It's things we do in the hospital, and then it's also things that they can do for them at home. And then this is just another resource. They've got several different resources on here. This is designed to be in the opioid treatment centers. Any questions about opiates? Like I said, this one's near and dear to my heart, so I talked a lot about it, but the rest of them are kind of short, so, because there's not a lot to say. Go ahead.
When you treat with morphine, do you eventually just slowly taper?
We wean, yeah. So you kind of wean by 10 to 20% every couple of days. And it's based on their scores. So we use a Finnegan neonatal abstinence scoring tool, so it's based on their scores. And if their scores are less than 8 and they continue to be less than 8 for 24 to 48 hours, then we wean. Yep. And then once they get down to a pretty low dose, then we'll space out the frequency of the dosing and eventually then get them off. Yeah. I know some places, I don't know if you guys have experienced it out in the community, send babies home with morphine or methadone. Yeah. Not much anymore. Is it going down? We've seen it. We've had babies readmitted to us who have been sent home from a different hospital, but we won't send them home with morphine or methadone. It's just too hard for them to be able to taper, and I mean, the dose is small. They're not really going to get anything out of it if they try and take it from the baby, but that's also a fear. All right, so anything else? Sorry. Okay, moving on to marijuana. Again, this is becoming more and more. Some of it's because the social norm has shifted, right? I think we're going to see a generation coming up that's going to be way different than, and it's a little bit frightening. So this is what I know about marijuana's effects. It is one of the most common substances used during pregnancy. A lot of times we don't know it's being utilized. If you look at SAMHSA puts out that every couple of years incidents, those numbers have definitely been increasing. 2 to 30% is the range, if you look at the literature, of usage rates, and that depends on age, and it also depends on socioeconomic status. So the younger you are, The more urban, poorer tend to have a higher incidence. So the use in pregnant women increased 62% between 2002 and 2014. So that's a huge increase. The metabolites of the marijuana readily crosses the placenta, THC crosses the placenta, and it also gets into the breast milk. So I'll talk about that in a minute. And again, the current levels, again, you know, the marijuana that was in our time, some of you are younger, is not like it used to be. So the amounts of THC in some of this marijuana that's out there is a huge concern, as well as what it's cut with. So it's another thing you never know. I got told, I remember, sweetest girl that was in the program, and we got talking. Her baby was treated medically, pharmacologically, and she told me that she did heroin and how it got started, and then she said, but I was a safe heroin user. I said, okay, what does that mean? I didn't know there was such a thing. So yeah, you just never know what it's cut with and things like that. But so the effect on the fetus of marijuana, animal studies show an increased risk of miscarriage. It's not human studies on that particular outcome. There is a potential for low birth weight and premature birth, double the risk of stillbirth, so second, third trimester losses. But the most worrisome aspect of the marijuana is the developing brain, right? We know especially in children, the effect that it has on the brain and the brain's development. It's more worrisome in a fetus who's got a brand spanking new brain that's trying to develop normally. So, withdrawal in these babies, we don't know. They may show some withdrawal signs. Some people have noted an altered response to visual stimuli, some increase maybe in trembling, maybe a high-pitched cry. But it's not a major problem as far as withdrawal signs go, and we don't keep those babies for 5 to 7 days typically unless there's other drugs on board. So both the AAP, American Academy of Pediatrics, and the American College of Obstetrics and Gynecology, that's ACOG, do not recommend breastfeeding when women are using marijuana. Moderate to high levels of THC are found in breast milk. So we do counsel our moms not to breastfeed. We can't force them not to do that, but we do counsel them not to because it's really not been found to be safe. And again, we're talking about a developing brain, right? Our brains develop into our early 20s. That frontal cortex doesn't develop until you're 25, 24, 25, right? My husband always said you don't get your brains till you're 25, and that's pretty much true. He has no medical background whatsoever, but that frontal cortex, that reasoning, judgment, part of our brains are not fully developed until then. So, and it does have effects in those areas of the brain. So we really don't know what kind of effects that can have on that developing brain. If you look at school-age children, there has been some human studies. They've shown gaps in problem-solving skills, memory and learning deficits, inability to remain attentive. So kind of those ADHD kind of kids, impulsive behaviors. They do have an increased likelihood of using themselves. And the studies that have been done, I mean, they use statistics all kinds of ways, and I don't know, you could probably always make anything work to your advantage, but what they did find was that even when you correct for some of those environmental factors that are occurring, they still have an increased likelihood of using. So, increased stress responsivity, so the stress responses are heightened, abnormal social skills, hyperactivity disorders, things like that. Any question about marijuana? The only thing that I would probably add to marijuana is all the studies have been on THC, right, which is the metabolite that produces the high. The CBD, which is, what is that? I can't remember what it stands for, but that's the part of the marijuana plant that they utilize for treatment for nausea and vomiting in cancer patients. And so that's more of your medical marijuana part of it. There's not been a lot of studies on that, but it doesn't give them the high. It doesn't have some of the same concerns as the THC does. So I don't know if anybody has any comments on that, if they know anything about that, but that's what I know about it, I guess. Okay, anything else about marijuana? Okay, Not a lot in the next couple of sections because the incidence of stimulant abuse and hallucinogen abuse is small, thankfully, and there's not a lot of literature out there. But so as far as stimulants go, and I mean, there's some research on amphetamines and methamphetamines that you're going to see. So those we kind of know something about. But those babies tend to be low birth weight. They tend to be born premature. Again, smaller head size. So there has been no link to malformations in therapeutic doses. So those pregnant moms that you might have in the community that are prescribed Adderall or anything like that, there really has been no link to poor outcomes with those kids. So, or any malformations. However, any stimulant readily does cross the placenta as well as the fetal blood-brain barrier. It also is especially stimulants are damaging to the placenta because they vasoconstrict. So that can lead to abruption. So the placenta pulling away from the wall of the uterus, it can lead to placental insufficiency, poor growth, premature birth, all those kind of things. So it does have an effect on the placenta and subsequently then on the baby. Stillbirth rates, are high for meth. Meth is a known neurotoxic agent. It damages brain cells containing dopamine. And dopamine is a very important neurochemical in the executive functioning, motor control, motivation, arousal, reinforcement, and reward centers of your brain. So dopamine is an important thing, and meth is a known neurotoxic agent. So it's a bad one. Cocaine in particular, there's been some studies on that because in the 60s there was a lot of cocaine use, so a lot of the studies are old, but I think still probably relatively, they hit home. So they did find neurobehavioral abnormalities. Commonly that presents between 48 and 72 hours of life, so they do go through some sort of a withdrawal symptom. So you can see the tremors, high-pitched cry, irritability, those kind of things. They also have abnormal auditory brainstem responses, so you can measure that, and that is abnormal in those babies, as well as abnormalities in their EEG, so the things that read your brain waves, there's abnormalities in that. Those are transient, which is a good thing, but there have been abnormalities with that. Prenatal cocaine exposure is associated with structural deficits in the baby's brain, so if you image their brains, structurally they're abnormal. And that can be associated with disruptions in functional connectivity. Long-term impacts, again, can be typically behavior problems, so aggression, decreased attention, those kind of things. Some of the things that we've talked about previously. Specifically speaking about meth, they've found increased learning problems, difficulty in completing or organizing tasks, again, structural brain abnormalities. Anytime you have a structural brain abnormality, that has long-term consequences. And again, in particular areas of the brain that are associated with cognitive performance. Emotional reactivity, increased incidence of anxiety and depression, oppositional behaviors, so oppositional defiant disorders, and then behaviors associated with ADHD. Questions about stimulants? Do you guys see much of it? I don't know, we don't see a lot of it. We've had a few, but not too many, at least not that we know. Sedatives, I think I only got 1 or 2 slides on this one. Sedatives are one of the drugs that will cause congenital malformations, or can, I shouldn't say will, it's not 100%, but much higher incidence of congenital malformations. And they may show some withdrawal symptoms. There's an acute stage, a subacute stage. Some of the same sort of things with some of the other drugs of addiction, but not a lot is known on sedatives. So that's pretty much all I have for that one. And then hallucinogens, your designer drugs, your LSD, your ecstasy, things like that. Limited data, and the data that I did find is only with PCP. So there's just observational studies. Again, no woman's going to take PCP so that we can study the effects on their babies. So they're just observational studies, and there have been reports of neurobehavioral abnormalities in the neonate, and you can see some of the problems that they have. But again, I mean, these are no long-term studies. We don't know what it does long-term for those kids. I'm sure it can't be wonderful. All right. That's all I have. Any questions? Comments? Yeah?
So you said did you say that you're not seeing a lot of babies born to alcohol addicted mothers?
No, but I'm sure we're missing them. I mean, you know, unless they have those classic facial features, there's no way to really know, unless parents are honest with us.
And then another question is, is there any like type of study being done in our area about the number of babies that die in our area from alcohol or drug?
Not that I'm aware of. Are you aware of anything, Melissa? Any studies? I mean, we aren't doing anything.
I mean, probably would know as far as the death review.
Yeah, right. They've got the death reviews.
But they don't come to the Marathon County Child Death Review. Those kind of deaths probably would happen at the hospital, and I don't know that they would come to Child Death Review. So I don't know where that data is.
I mean, a lot of them, so we've had a couple, you know, a lot of them happen in the womb. So before the baby is actually born, and I don't know that anybody tracks that.
We don't.
Because you don't consider that do you consider that a death when you look at those?
We don't review those.
Yeah. So, nothing. Yeah. All good areas where probably more needs to be done. Yeah.
So not seeing a lot of FAS in the newborns, can we assume that the moms are doing a better job of not using alcohol while they're pregnant?
That's, the literature wouldn't support that, I don't think.
It doesn't support that. So I mean, I'm just curious, you know, why the discrepancy between the reality of the situation and what your observations are.
Yep.
You said 1 in 20 years?
I have seen one in those 20
I mean,
years. That I know of, yes.
That just kind of is astounding, you know what I mean?
It is astounding.
Yeah.
What
I
we
agree.
see in the Start Right program, we see pregnant women who will say that they are using alcohol and have stopped for their pregnancy.
Okay.
We do see a fair amount of women who are using marijuana. They don't even consider that to be a drug.
No, correct.
And if they're using heroin, then they use marijuana because they think that that's better. And you could hypothesize that perhaps they know alcohol is not acceptable, so they might use marijuana as well. So that there's a pretty high rate of that just from our observation.
Yep.
The other question I had on smoking.
Yeah.
There was a time when I was in practice that I was associated with the First Breath program, which is kind of a Wisconsin program that has rewards for moms that quit smoking while they're pregnant. Is that still active?
Yep.
We do. In the Start Right program, we offer it to all women who are smoking, as well as there's a My Baby and Me, which is alcohol use, and they're incentivized to go through screening and treatment, and we have a pretty decent uptake of that.
That's good to hear.
Through Start Right.
Yeah, and if we can get those moms into that program, there's a lot of resources available to them.
Yep, there is. Very good.
Yep. Anything else? Yeah.
What do you do with that mom who's in the middle of labor and is coming off of a high?
So we treat her. You have to treat her because the baby's also probably feeling the same way. So it's less of a risk to treat the mom than it is to let them withdraw like that. So we would treat the moms. And we typically, so we'll get our adult specialists and that will treat them. The obstetricians will manage the labor, and then one of the hospitalists will manage the withdrawal. And you know, if mom's doing okay, baby's gonna do okay, so at least for the time being, so yeah, that's what we do. It's a team, it's definitely a team, yeah. Because I mean, obstetricians are really not trained in managing addiction like that. I think we'll see a shift in that. I think in medical school they'll start incorporating more of that, but they haven't. I mean, maybe they do now, but previously they haven't incorporated much of that. And we still are lacking in addiction specialists as a whole. Our whole community is lacking. There's waiting lists and it's a problem. Love to see more providers that wanted to do that. They don't let nurse practitioners. so I can't manage those patients at all, but.
Policy change
Yep.
coming.
Right.
So, thank you.
Yeah.
Round of applause for Sarah. She did a great job. As we close, I'm just gonna, she had mentioned that if you've ever seen someone withdrawal, it's no different for the child. I'm gonna show you just a short clip from a summit that we did a number of years ago. Now, wow. It's a couple years ago. With Dawn Perez from Social Services, really kind of helped paint, that picture of what that looks like in a child.
Well, I just want to thank you all for just giving me this opportunity to share a little bit, just a piece of our world at Child Protective Services. And that also includes juvenile justice services. We have economic support as well, child support at social services. So really thank you for giving me this opportunity. And I want to start by sharing a story with you. And this story would be much like any one of the cases that we might see or work with at Marathon County. So if I can just ask you to just mentally picture, image right now, in your mind right now, picture a person going through withdrawals. And what that might look like is that person would probably be sitting in a very dark room because light is really hard to tolerate when you're going through withdrawals. For all sakes and purposes, we'll make this a female. So she would probably be drenched in her own sweat from going through those withdrawals, maybe even drenched in her own feces. She would probably have lost weight because of this struggle that she's going through, this withdrawal. She may be crying uncontrollably, and she may be shaking and unable to stop that shaking. So she would be physically exhausted because of what she's going through right now. And what I want you to picture is that she's 1 day old. So this is a newborn infant that has spent the first 24 hours of her life in pain, sweating, shaking, and crying inconsolably. This is really, really hard to watch, and this is something that we see all too often in our job right now. So you probably want to ask yourself, why did her mom use when she was pregnant? Why couldn't she put the needs of her unborn child over her own needs? Why couldn't she go and get help? And the answer might surprise you, because right now in this area, we don't have services for that type of help. So we have to contract with agencies in Milwaukee to provide that type of service to that mother. And for our uninsured and our underinsured, that comes out of tax levy. There's not even the opportunity to pay for those services. So I want you to keep that in your mind when you're asking yourself, why didn't she do something? Because most often what we hear when we are intervening is, where do I go? Where could I have gone and gotten help?
So I'm going to stop it there. So on our YouTube channel, you can view all of our videos. So all of our meetings, all of our special trainings. This here is a 2.5 hour actual training on the trends of addiction. I would recommend you go back and you can see what the topics are of each meeting, and you'll be able to see a little bit more. I mean, it's a resource that's out there. You can always draw back. So like this meeting, for example, will be recorded. Will be posted probably within a week or so. Get the nod from buddies at Public Access. Thank you. But it is something that's out there. So I'm just going to close it with that. I think Dawn did a great job of painting the picture for us, and not much has changed since she spoke at that point. So thank you, everybody, for coming. If you have questions, you want to hang around, that's fine. Go ahead. We are at 15 seconds to 1. Have a wonderful rest of your afternoon. And we haven't said anything official for October, so if anybody has anything that they're dying to know more about, make sure you write it down on your evaluation. But December, we will focus on medication abuse. Have a good afternoon.